Fighting Blindness Canada's View Point education series shares the latest in vision research, provides opportunities for you to ask your questions, and connect with other people who are living with a blinding eye disease. The session you're about to watch is a recording. To learn more about the research we fund and upcoming programs and events, please visit our website at fightingblindness.ca. Viewpoint is proudly presented by our platinum partner Bayer and supported by our gold partner Roche and silver partners AbbVie, Astellas, Beacon Therapeutics, Johnson & Johnson, and Specsavers. Thank you for watching. We hope you enjoy this session and share your thoughts with us in the comment section below.
I have with me Dr. Geoff Williams, who I'm sure is familiar to many of you. I'm so pleased that Dr. Williams has joined us today. I'm going to give him a quick little introduction. So Dr. Williams is the Clinical Associate Professor of Ophthalmology at the University of Calgary and is the Medical Director at the SAEC Surgical. He practices at the Southern Alberta Eye Centre, operates at Rocky View Hospital, and serves as the Vice President of the Canadian Retina Society. So we can do this a couple of ways. Oftentimes I have like starter questions, but there are so many people in this room today. I think we'll just open it up for your questions about AMD for Dr. Williams. So if you have a question at any time, please just raise your hand and wave, and my colleague Kathy will bring around the mic. Maybe just to set the stage, Dr. Williams, can you talk a little bit about, what is AMD? What's the difference between wet and dry? Just a real brief introduction.
Sure. So thanks for coming, and thanks to the people that I recognize for coming to make this a little bit less scary for me. That's great.
I'm just going to move this a little closer.
Okay.
Be
real close to the mic. Okay. Just basics, real basics. The macula is the very, very specialized portion of the back of the eye where you see 20/20, and it has the large concentration of cones there that allows you to see both color and fine detail. And that specialized part is kind of like the center of the bullseye for the retina. And so when we talk about macular degeneration, that area is what is affected by a variety of conditions, aging being one of them. Genetics probably plays a big portion of it. And then that degeneration process has a variety of manifestations. There can be what we call wet and dry, wet being new, growing, leaking blood vessels that progress fairly quickly and cause damage to the center very quickly. Or the slower kind, which is the dry macular degeneration, and it's what we call atrophy. So it's just like the tissues are just thinning and kind of disappearing. Those two still occur in the same place. So they're both called macular degeneration, but they're different processes. And there's other things that get confused with those conditions as well because they happen in the macula. But that's what we're talking about, is basically dry and wet macular degeneration.
I'm wondering as a start too, if we might just do a show of hands in the room, how many people have been diagnosed with wet macular degeneration?
Majority here.
Yeah. And then what about dry?
Oh.
Any who have both? Yeah. Okay, interesting. That's I would say it's probably about 50-50.
Indeed,
yeah.
It is, yes.
Yeah.
So.
Do we have any questions from the audience to get started? Okay, over here.
Yeah, what's the newest drug that's out for injections?
So the newest drug, so newer treatments, like for the injectables? Is that what you just asked? Yeah.
Yeah, so there's a couple of new kids on the block. Just for context, it's now 20 years since the introduction of the first what's called anti-VEGF. And so we started off with 2, and then it rapidly went to 3 and 4, and now we have 6. So there's 2 new kids on the block, if you will. One is called aflibercept HD, so it is an older molecule that we've had for years, but now at a 4 times dose. And the other one is called faricimab. And you won't see those names advertised on TV. So faricimab is something you call Vabysmo, and Eylea HD is the other one. So those are the 2 sort of latest drugs that we're actually using in the clinic. There's a third one which I won't mention because we basically stopped using it.
And the benefit of some of these newer drugs is that they would last potentially longer between injections?
Yeah, so the main advantage is that for many people, when this whole process started, especially 20 years ago, it was monthly injections, as many of you know. The advancement in the technology and the advancement even just in the dose has allowed us to get some people, not everybody, but probably most people, to an injection that's every 8 weeks, every 12 weeks, even every 16 weeks. And so it all depends on the disease. There's people who are tougher to treat than others. And these drugs aren't yet completely available to everyone, I guess you could say right now. That process is changing in Alberta. So we're hopeful in the near future all of them are going to be available to us to use any time that we wish to inject them. So right now there's some limitations, but there are changes that are coming that'll allow these new ones to be used more, I think.
And am I right in assuming that everyone is different, right? So every patient is different. Things might work differently for different people. The span between treatments is not always consistent.
That's right. And so injection clinics are basically a series of trial and error experiments. Everybody is a different one. And so you use the drug and you start every 4 weeks, and then you try and do what we call treat and extend. So you go maybe 6 weeks or 8 weeks, and then you see if it works. And if there's a problem, the swelling comes back, then you have to go back to 6 weeks or 4 weeks. And so you do this trial and error process, and some people you can extend all the way out to 12, 16 weeks, and some people you can't.
Where are we going to go? Kathy at the back there? We'll start at the back.
Could you please tell us the name of those drugs again? The new ones?
Yeah, I'll use the commercial name even though you're not supposed to, but Vabysmo is something that you would see advertised.
Vabysmo?
Yeah, Vabysmo. And Eylea, which is Eylea, and then HD after that.
Thank you.
So,
Okay.
you're welcome.
And there's some at the front. We're working our way forward.
Hi, is there anything new with dry AMD, and maybe talk a little bit about some vitamin A derivative type thing that might be on the horizon too?
Yeah, so there are 2 commercially available treatments right now in the United States for dry AMD. Unfortunately, neither of those are approved for use in Canada. One of them is probably not going to ever come to market in Canada. Health Canada, along with Europe, has decided not to support it. It is supported in the US and Australia, so there's a difference of opinion as to that particular drug. The second drug is still under review with Health Canada, so we are waiting. We're expecting some sort of answer by the fall, and it's a different process for every one of these things, so we're hopeful that we'll have at least one of them in our hands. The important thing about the dry AMD drugs is that they are injectables, so you still have to go through the process of getting a regular injection somewhere between 4 and 8 weeks for these drugs. And then they don't have quite the wow factor that the anti-VEGFs did. Like anti-VEGFs, for a lot of people, they improved at first and got kind of exciting, and you keep going. With the dry AMD drugs, you slow down the degeneration. So you still continue to lose vision, unfortunately. You just lose it slower. So it's hard to tell if you are really doing well or not.
And I can't remember if you mentioned it, but this is not just for any dry AMD. This is for geographic atrophy, which is like a severe form?
This is for geographic atrophy. Dry AMD isn't as well characterized, I guess you could say. We spent many, many years looking at fluoresceins and giving different types of wet AMD different names. In the end of the day, we kind of lumped them all into one bucket because we treated it the same. We're still trying to learn about the different kinds of dry AMD and what we call the phenotype, or its appearance is a little different in different people. There's certain common things, but I think that there's a variety of processes that we don't fully understand yet, and we're still learning about that.
The vitamin A derivative?
Oh, the vitamin A derivative, to date, I don't know of anyone that actually makes any kind of difference. That was also used in the past For retinitis pigmentosa, again, didn't seem to show much of a difference. So I'm not aware of anything that actually makes a difference in dry AMD with that. So.
I'm a sufferer from dry AMD, but haven't really lost much vision yet. But from my father and grandfather, I know where it's going. My optometrist is strongly suggesting a treatment called Macular, and my retinal specialist doesn't see any value in it. I'd be interested in your views.
Okay, so we're going to go backwards a little bit on this one and just kind of explain. So there's a big difference between Health Canada approving a device and Health Canada approving a drug. And the drug goes through a very rigorous process, and with a lot of patients that are treated in large, what we call randomized studies, so that you're basically proving that within a reasonable margin of error that it works. Approving a device doesn't go through all that, and there has been a study done on the Macular device, and the results of that study were, this is my opinion here, is sort of weakly positive. From a scientific point of view, it's not a rigorous study, it's only a single study, so most of the time you want to see larger numbers of patients treated and multiple sites and get enough data to actually really get an idea whether it works or not. Unfortunately, Macular is not in that position. It's not a big number of people. It's not at multiple sites. So it needs more research for us to be able to really recommend it or not. So at this point in time, the Canadian Retina Society and the Canadian Ophthalmological Society are not actually supporting it because we're saying that the data just isn't there to say that it proves that it works.
Thank you. That was quite helpful. But I read the study myself, and I noticed that it dealt with people who already had very severe vision loss. And I asked them a question, whoever sent me the study, about how it would work for someone who had very little vision loss, which is my current situation. Never did get an answer. But anyway, I think you've been helpful.
Thank you.
What about the treatment called microcurrent?
Microcurrent and Macular are the same thing, as
Same
my
thing?
understanding, yes.
Yeah.
There's another.
Oh, there's another one back there. She got your eye
He's
first.
moving back.
Okay. Oh, sorry,
just-
there's somebody with the
We'll get to
microphone.
you
We'll get
next,
to
yeah.
you next, yeah. Cool.
So quite a bit of the research is on chemistry in the eye and looking at certain molecules and what they do and how to treat them. There's a wave of people living longer and better diagnostic technique, and it's coming at us. There's a ARED study, of course, which is iconic for the amount of work that was done. And then out of that came a commercially retail available formulation to supposedly enhance healthy eye. But I guess I'm wondering, in the world of research, and haven't seen a whole bunch listed on various university sites, and I know it takes a lot of work, but diet and other environmental factors, why aren't we doing research on that? And is there some particular organization that might be doing it that needs supporting?
That's a really good question. The answer from my perspective is that there's only a fairly small effect that we can demonstrate from the use of those multivitamins plus zinc. And we also garnered some information about the fatty acids and so forth in diet. And we teased out some dietary questionnaires from these thousands of people that were in the study, and found some interesting things, I guess you could say, that eating fish was a very positive thing to do within the study. So much so that it masked the effect sometimes of taking the supplements, because the supplements didn't have a really big effect. So I think the research is looking elsewhere into the genetics and other mechanisms, because they sort of feel that the supplement part of it isn't really totally the answer. It's a small piece of the answer. So.
Was that all fish or any particular fish?
Cold water fish, I believe, but all fish, I think, was included in the questionnaire. So, yeah.
Can dry AMD get converted into wet after some time, or is there any time frame?
That's a good question as well, because basically, if you watch the audience here, and people put up their wet and then dry and then both, it was something like everybody did the wet, dry, both. So the answer is basically the way macular degeneration starts is usually a little bit of dry, spots and dots we call drusen. Okay. And you start to see those appear in a variety of places. And so the people who develop the wet kind of get the additional wet kind, but they still have the dry in the background. And so you basically have both at some point when you have the wet. There are people that have the dry and never have the wet. And there are people, fewer of them, that have the dry and then much later will occasionally develop a little bit of wet, but that's not generally why they lose the vision. It's a bit different pathways, but the answer is yes, you can go from one to the other and have both.
It was this lady here.
Right
The
in
white
front.
sweater?
Yeah.
I was wondering what you were hoping to find with the new medicines you were talking about.
Okay, so there's more than just longevity to the new medicines. They have what we call dual mechanisms of action, so that I mentioned anti-VEGF, and that's the big one for wet macular degeneration. But there are other factors, so there's something called Ang2, which is one of the molecules, helps to block that to help stabilize the vessels. The other one is platelet-derived growth factor, which it blocks, which we think has a small role as well. And so we're learning now, after 20 years, that anti-VEGF isn't the only answer. There's other factors, and you might be able to enhance the effect by having molecules that actually do more than one thing. And this is where some of the research has gone to from 10 years ago and is now in our hands. So.
There was a question over here, sir.
Okay.
Yeah.
I'm on my way.
All right, moving our way across.
In your description of the spots and dots, statistically, we're dealing with cells that are broken down.
Yeah. Yes.
So in the retina, there are, 10 million cells?
Yeah, more than that, but keep going.
So when you do a clinical trial of 3,000 or 4,000 people, the geographic atrophy of their individual spots and dots is statistically beyond comprehension. Any clinical trial that deals with nutrition would be doomed to failure because of the blur that comes from individual geographic atrophy. So your suggestion that the supplements have diminished in significance, I understand you correctly?
Yeah.
I found over the last 20 years taking supplements and changing my diet have been very effective in stabilizing my geographic atrophy. Just mine.
Yes.
It wouldn't apply to everybody.
Right.
But the idea of nutrition as a stabilizing influence, I would suggest is a strategy worth adopting instead of just letting the family history run amok.
Oh yeah, very fair point, very good point. Yeah, I'm not suggesting that you don't take the AREDs or eat fish or any of those things. Those are what you can do. But like you mentioned, that worked for you, but it doesn't work for everybody, and that's why you have to do thousands of people. And then the next thing that happens is that when you do thousands of people, that costs a lot of money. And the next question is, well, who's going to pay for that? And so there's not a lot of money to be made honestly, truthfully, in a lot of these supplements because they can be produced by anyone. Zinc has already been invented, and so if you found some miracle cure out of zinc, you wouldn't have a patent that would allow you to make the money to recover. So it's a very interesting problem that we have in research.
So is gluten important for eye health or not?
Just want to repeat that
Yeah.
question for the camera. So asking
Oh.
about lutein, if it's important.
Yeah,
in health.
lutein is important, yes. It is one of the components. There are supplements that are lutein alone, which we don't think is really all that helpful because lutein is in the diet. Like you'll find it in an egg yolk. But you do want to have it as a component of your diet. So it's a good thing to have in your mixture of supplements, but not as the sole thing.
Question over here.
I wanted to thank you for taking your time today, and it's a privilege to stand beside you. I've always sat, I didn't realize how tall you were until today, so thank you. I was intrigued to come today for many reasons, but one of them was to hear about stem cell treatment or whatever it is, and I don't know if it has any bearing on the macular situation. And the other question is, diet is important. Is exercise also important to keep the blood moving? Does that have an impact? Thank you.
And the answer to that is yes, over many years. And so when the ARED study was done, for instance, it had about a 25% difference over 7 years for those supplements in the various things that they looked at. And so health in general, that's diet, exercise, all those things, yes, those are important. To come back to your question just about the stem cells, the stem cell therapy got a lot of hype and notoriety, I guess you could say, and a few years ago you heard a lot about it, and then it kind of died down. And the reason it kind of died down is it wasn't working. And there might have been some initial successes, but then they sort of turned into failures and scars, and people didn't see very well. And so we discovered that one of the layers in the back of your eye that's very important is what's called the pigment epithelium, and that sits between your retina and the choroid. And so it's like a sandwich of layers, and you need all 3 layers to see with. And so if you were to try and replace that pigment layer, for instance in geographic atrophy where you're missing it, and try and place it, you can't just inject it in. You actually have to lay it down in a sheet, and those cells have to be oriented properly. There's an up and a down to every one of those cells, and they all have to be up. So how do you do that? So then they're developing microfilms to be able to put them on that sheet in one layer, in the proper orientation, in the back of the eye, and that turns out to be pretty complex. And then it has to be supportable by the blood vessel layer in the back of the eye too. So you might be successful in actually putting that layer of cells there, but now what if the blood vessels in the choroid are not very healthy? Well, it fails. And all the while, the retina on top has been dying maybe for years. So it's not coming back if it's had a chance to die. So there's a very thin sort of window of opportunity to actually perform a procedure like that, and we're just not there yet in terms of all these various factors. So stem cells really, at this point in time, are not sort of coming to us in the clinic.
Can I ask a follow-up about that? We were in Edmonton a couple of days ago doing a small event for people with AMD, and there was a person there who had been approached or found out online about a clinic in Florida who was going to inject stem cells in her eye and cure her vision. And I wondered if you could talk a little bit about some of these unregulated things.
Yeah, thank you for mentioning that, because that's really important. And I've seen these patients myself. And a couple of the patients I saw early on, this is a few years ago, when stem cells were kind of getting exciting, if you will. And there were clinics that were literally just injecting some cells that had been taken from some other part of the body and spun down and then put in the eye, and it caused huge inflammation problems, and those eyes went blind in a matter of days or weeks. So it was very, unfortunately, very unethical treatment that cost those people a lot of money. And then I saw some other people that looked like nothing had ever happened to them at all. And that's because probably, and my view, they were likely injected with something that was innocuous, and they got charged $10,000 and nothing happened. And so, yes, it's safe, but it wasn't effective. But it was a wallet fattening procedure, as I call it. So.
Yeah, so we do get questions at our health information line about this all the time, and maybe the warning signs I always suggest to people is, one, that there are no approved stem cell treatments, point blank, but also if they are asking you to pay for treatment, that is not a regulated treatment. Clinical trials will never ask you to pay for the treatment. Is that fair?
It's a very fundamental part of research is that if you are volunteering your time and your eye and what remaining sight you might have for a clinical trial, first of all, that has to be voluntary. Secondly, you should not be paying for any part of that in any way. And thirdly, you should understand the science somewhat behind it before you enroll. And that's our job as clinicians, to identify the people who are potentially a candidate, make sure that it's reasonably safe for them to be considered as a candidate, and finally explain it to you so that you understand and so we both understand what it is that you are about to embark on.
Because ultimately, clinical trials are experiments. They're not treatments. We're trying things out, seeing how it goes.
That's right. And the hope is that you are the patient who is getting the real treatment, but you could just as easily be what's called the placebo, which means you're getting the dummy treatment, and you don't know, and the doctor doesn't know, and that's why we have what are called masked trials. So there are people in the office who know what you got and people in the office who don't know what you got, so that there's no influence from any of us into how the outcome is measured, so that data is what you'd call clean, so that when you add it up over hundreds or thousands of patients, you've got a real scientific answer.
Absolutely.
Supplementary question. There are techniques or equipment out there to help with size and light, but is there anything to help with the distortion?
Oh yeah, that's a tough one. Yeah, so vision loss comes in many ways in the macula, and sometimes when you develop scarring or wet AMD or even dry AMD, you get a distortion, so straight lines are bent. And this can be a sign, a very important sign to look for. If that starts to develop, it means something's happening. You need to get checked. But if you have been seen and treated and you have this problem, unfortunately, we don't have a way of squeegeeing anything back into place because we don't know where it started. So there's just no treatments. And I also deal with this as a surgeon. When you have other macular conditions where you operate and you remove scar tissue and that kind of thing, you can, what I call, improve the vision by letting the retina relax into a better shape. But I can't shove it around and put it back to where it was.
I just wanted to ask for another comment about zinc. I've been taking Vitalux for many years, and I knew that lutein was very important, but I really haven't heard anything about zinc. Mm-hmm. Now, for the benefit of people here, I was diagnosed with AMD back in the 90s, and I wasn't 90 then, I was in my 40s, but I'm in my 70s now, so and I actually am doing quite well. And but I just want you to say something about zinc, because that, I guess it's on me not to be reading not to be reading the product label, but the retina consultant that I've been seeing ever since I've moved here for the past 4 or 5 years has never mentioned anything about zinc to me, but he does ask me if I take Vitalux. Okay, so can you elaborate on it for me, please?
Yes, so zinc is one of the half dozen components of these supplements, and it is thought to have some antioxidant properties, and therefore it's included. There's 2 different formulations of zinc. So Vitalux has a slightly different one than Preservision, for instance, but it's still elemental zinc that ultimately you're getting into your body as a antioxidant, but it's just part of the mixture. So there's still some unknowns about every one of these components. There's unknown reasons why some people benefit from the supplements and some people don't. And so that one, I don't know that is necessarily going to be sorted out, if you will. I don't see it, there's not going to be another AREDS trial coming down the pipeline as far as I see it.
Are there other modifiable risk factors? I mean, we know age, obviously, right in the name, that's number one. But are there other things that people could change? We've talked a lot about diet, but are there other things?
Well, there's a big one, and it's smoking. I don't see very many people smoking in the room, so that's a good thing. I hate to be preachy about it, but smoking for both diabetes particularly and for macular degeneration are really, really bad. So we try to discourage that as much as possible.
How about alcohol?
How about alcohol? Oh, for my sake, I really hope it's okay. Alcohol falls into the general health categories, if you want to call it that. So there's nothing specific with AMD and alcohol, but things like blood pressure and your overall health do have some aspects there. So as far as I'm concerned, to acknowledge that it's reasonably safe. I have only one rule for my patients, and that is you can have a drink, but just don't fall down the stairs.
I think that's a good life advice for all of us, actually. The question was about sunlight exposure.
Yeah, sunlight is a good one because it is modifiable with sunglasses. It has a small effect. It's been shown in studies that it's mainly the ultraviolet light that is problematic. Fortunately, our cornea and our lens, natural lens, and our implant lenses block a good deal of that ultraviolet light. And so the next sort of problematic light is blue, which isn't as energetic and isn't as problematic. Over a lifetime, if you're a fisherman on Chesapeake Bay where the studies were done, do you get a little more cataract and a little more macular degeneration? The answer is yes. But in northern climates, we're in the dark half the time. It's probably not as bad here. In the northern climates, I think it's more our genetics that have anything to do with it than the actual sunlight exposure.
Device usage. Does that have anything to do with it?
The question was device usage, so like the blue light from the phones.
I'm not an advocate of that in that I don't think that blue blockers and all those kinds of things really have that great an effect for the reasons that I mentioned. It's not that problematic as far as it's good marketing aspect, but there's really no science that says it's that bad for you.
But it doesn't use a device or too much TV or whatever. Does that affect your chance of getting macular degeneration?
I don't think so, no. How you use your eyes, I tell people your eyes are not made out of rubber. You don't wear them out like you do a tire. You can use them for as long as you want and in ways you can. I mean, you can't look at laser lights, but you can certainly do everything else. So.
And there's a question over here.
I got AMD at age 45, and I just wondered whether my kids, what age should they start checking if they have AMD? What precaution they can take?
Yeah, that's a good question because you're rather young to have developed that at age 45, so that strongly suggests there's a genetic component. There's about 32 genes that have been implicated. The number is actually higher than that, but the effects of these genes get smaller after about the first 32, and there's a handful of that are right at the top of the list. And the problem with the genetics of 32 genes is that your kids get some mixture of these things which you don't really know. And so it's not really easy to say it's going to follow any particular kid in the family. And so their genetic mixture is going to be different for those 32 genes. So if you're unlucky and you get sort of a bad combination, a bad hand of cards, you might get macular degeneration, but it won't necessarily be passed on that way. Having said that, you asked the question about when should they be checked. So In generally, AMD doesn't develop much before the age of 55. So if kids are 55, then yeah, it's probably time to get a checkup done, photograph or an examination of the macula to look for drusen and those kinds of things.
Can I ask, you mentioned the genes. We talk a lot about genetic testing for inherited retinal diseases, for example. Are there genetic testing for AMD? Are they worthwhile?
Okay, full disclosure, I'm actually an investor in a company in the United States that actually does genetic testing for AMD. It hasn't been something that has really taken off because to date there really hasn't been any specific therapy that you would apply differently if you have one gene versus the other. And so it's mostly a matter of curiosity and how much or how badly do you want to know. So there are genetic tests available that can tell you, stratify you into high, medium, and low risk for at least wet macular degeneration.
What is PEBT drops? And what do they do?
What is, sorry?
PEBT, eye drops.
PEVT?
B like baby.
Oh.
Tom.
PEBT.
Yeah.
I'm sorry that.
They're eye drops.
Eye drops. I'm sorry, I don't know anything. That doesn't ring a bell with me at all.
Used for dry.
Used for dry eyes, you mean, or
no,
or dry macular degeneration? There's no topical therapy that's of any effect that we know of for dry macular degeneration or wet macular degeneration. There was some research for a while that was looking at a topical therapy, but it ultimately failed.
Eagles have really good eyes. Has anybody used eagle eyes to check and see how to cure macular?
Well, yeah, but the problem is eagles don't live to be 85. So.
It's like a good question, like carrots.
Yeah.
Eat more carrots. You could feed the eagles.
I have a question, just a quick one.
Yeah.
Floaties, do they impact the
floaters? The floaters in your vision?
Yeah, floaters in your eyes.
They have no impact on AMD specifically. Everybody, to some extent, has them, whether you see them or not. And it's a natural degeneration of the vitreous gel in your eye. It's made up of protein and water, and gradually the proteins kind of clump together and you get pockets of water. So you get strings and strands and dots, and that's kind of a natural aging change, but not, it's aging, but so is AMD, but they're not related. So there's, oh, okay.
But back to Macular again,
Yeah.
Dr. Williams.
Yeah.
This is a brochure that was given to me by an optometrist who seemed quite eager for me to pursue it. It's very, very pricey, so it leaves some suspicions in mind. Another optometrist I talked to for a second opinion, he was vaguely familiar with the treatment and wanted to actually obtain more information, which he wasn't all that successful in getting. So with your comments, it sounds like ophthalmologists are not really on board with this. Optometrists are. Would you have any comment on that? Because there seems to be a division there between professionals.
Yeah, it's, well, I'll go back to my earlier comment is that the study and the science just doesn't tell us whether it really truly works or not, which makes it problematic to charge for something where you're not really sure. So the treatment is being...
You know how much it is, eh?
Yes,
Yeah, okay.
and the treatment is being delivered in optometry offices. Generally, there's I know of maybe one or two ophthalmology offices in the country, but to my understanding, it's mainly optometrists' office that are delivering the treatment. But we just, as our societies are basically saying now, the science just isn't strong enough to support it one way or the other.
Thank you very much.
Yeah. There's a gentleman right in front of you there, Catherine. Yeah, this.
While
Yeah.
I'm here. Dr. Williams, just wonder what your thoughts were on red light therapy for dry macular degeneration.
And that's something that was looked into a few years ago, again, weak science and weak numbers, and we haven't seen anything that really was any benefit there as well. So it's kind of in the same category. So.
We have time for 2 more questions. So.
I suffer from something else called temporary vision loss, which sometimes was originally diagnosed as having like a TFA, like a tiny stroke in your eye. I've had it hundreds of times, and I'm just wondering, is there any connection between that and age-related macular degeneration?
The answer is no, but you just keep in mind that your visual system is your eye and the optic nerve and all the way to the brain, which is in the back of the head here. And so anything that affects the circulation at any long way along those pathways can affect your sight and your perceptions. So if you're talking about something like, say, a migraine or what we call an encephalgic migraine, meaning you don't get a headache, but you get visual symptoms that usually come and go in a matter of, say, 15 minutes and resolve with no headache, that's an encephalgic migraine. And it relates to the blood vessels back here in your brain, nothing to do with the eyes.
My case, it generally lasts 1 or 2 minutes, and then
Could be.
the eye goes gray, and then it's better.
Yeah.
I think we have time for 1 more question. Over here. Great.
I don't have a question, but I have a suggestion. Because of some of the comments that have been made here about treatments that are quite expensive, is your association going to be, making public statements? I'd like to see something when I'm watching the news about some of the things that are available to us. We are a desperate group of people to remain independent as we grow older. We've been struggling with this. I came here today, hoping, that there was just something on the horizon. There is a lot, because I got a lot from you, and I got a lot from the other sessions and support. But let's find a way to stop people from putting up $2,000-$3,000, whatever it is, for those kinds of treatments that are just kind of depleting the few resources that they have when they could be buying, some of the wonderful assistive technologies that are outside today, So I'd just like to make that suggestion. Thank you.
Thank you, actually, for making that point. I don't think you'll see it on the news, but if you go to the website, for instance, of the Canadian Ophthalmological Society and the Canadian Retina Society, there's a statement about Macumera on both of those websites. So if you wind up doing your online research, I guess you could say, hopefully you would run into one of those statements at some point. Yeah.
Well, I think we're going to have to end it there. I want to just say, if you have questions that weren't answered today, we have a health information line at Fighting Blindness Canada, which is staffed by myself and one of my colleagues. I am not an expert like Dr. Williams, but I've done a lot of these sessions now. I've learned a lot. I have lots of resources that I can help with, and we can help you find resources that you need. So I think in your program is both, but the email is healthinfo@fightingblindness.ca, and I would love to hear from you. I want to thank all of you for being here and all these fantastic questions. It's been such a great discussion. And of course, Dr. Williams, thank you so much for this. It's been great.
Thank you very much. Thank you.